Uh, this is Dr. Muzna. I'm one of the baby doctors. I believe I am talking to Jenil, mother of John.
Yeah, yeah. I'm General.
Thank you, Mrs. Jenil, for coming over here, and we'll discuss about John's condition. Would you like anyone to accompany you while we are having this discussion?
No, doctor, my husband is not here. I'm alone and I'm in pain. Doctor, tell me what want to say.
Okay, okay. I would just like to know, till now, what update have you received about John?
I'm not happy, doctor. My baby, I got to know that my baby didn't cry and they took to an ICU. I don't know what is happening with my baby. I'm really anxious, doctor. What is happening?
I really appreciate your concern, and I'm over here to alleviate it and to help you to understand better. Is it fine?
Yeah,
Can we
doctor,
move ahead?
Karian. Yeah.
Yes, as we know that John, as you rightly said, had a difficult delivery and he did not cry. He required, he was a bit limp, and we required to give him oxygen and some kind of help for him to cry. Are you with me,
What,
Mrs.
doctor?
Jenil?
Like he's just delivered, and you need to give this oxygens and keep and this sort of what is happening, doctor? Is my baby really serious?
Yeah, yeah, I do. I can see that you're really worried about John, and so are we for his health and rest concern. Hence, we are trying. I'll try to explain to you that what has happened and what are we planning to do. Okay, are you with
Okay,
me?
okay, doctor.
So he did not cry initially and required some help with oxygen. And right now, in order to help him to improve better, we want to give him something called as a cooling therapy, Mrs. Jenel. So do you know about cooling therapy? Have you heard anything or read anything about it?
No, doctor, I have never heard this. Like a small baby, and you are cooling his head, or what is this? I'm. It's is it? Are you joking or are you serious, doctor?
Yes, Mrs. Jain. And I can see that this sounds really scary. I know it's going to be difficult for you to take it at the first instance, but let me tell you that the schooling therapy is something which is new and which has come up in order to help you, which is basically has been practiced since many years to help babies who have suffered this kind of a problem at birth, not crying easily and requiring oxygen. Are you with me, Mrs. Jenil?
Yeah, doctor. But you said it's very new. Like, are you testing this procedure?
Sorry, that was a slip of my tongue. I wanted to say it's something which many people have not heard about. It's not new, but
Okay.
it has been used since many years. And this cooling therapy kind of helps the brain cells, the brain cells to heal over a period of time.
Okay. So, does it have any side effect, doctor?
Yes, I can see your worry and your concerns about John. Well, there are side effects which we are going to continuously monitor and try our best to reduce. Like we are going to monitor for the temperature, for the heart rate, for the blood pressure. Do you know the way the heart is beating, the way there is the blood pressure, the way the child is respiring, what is the blood sugars, right? And we are
Okay.
going to do certain blood tests also to see that there are no side effects which come up so that we can stop if at all we feel that there is something coming up like that.
Okay. And then, doctor, after putting this head cooling, my baby will be completely fine.
Yeah, I can see that you're really worried, you're concerned about John. Well, this therapy helps a lot of newborns who have suffered this kind of problems at birth. In fact, when they grow up, their development is much more better than those children who have not received this kind of therapy. Am I
Okay.
clear? Has it been?
Okay, then like his life is at risk now, right? If I don't agree.
Well, this is a valid question that you have. Well, more than the life quantity being at risk, we would like to have a good quality for John, that he kind of has no problems after he grows up, like in his walking, in his jumping, his running. All these kind of milestones are normal per se. So we don't want that to get affected. Hence, we are giving this schooling therapy.
So, doctor, beside this, like, how will you monitor baby Jones this conditions? What else you are doing now? You doing any scans or anything?
Like presently, as per our consultant, we are going to go ahead with the cooling therapy with the cooling blanket. Are you with me?
Yeah, yeah.
You know, we'll put him on a blanket, we'll continuously monitor him, and we are going to cool his body so that his body and his brain heals over a period of time, over 3 days that's going to be there. And then slowly we will start reward, means we'll stop the cooling therapy so John will have the normal temperature over a period of time. So this kind of a rest will be very healing for John.
Okay. So, is there any how will you monitor like baby is improving or deteriorating?
At this point of time, we are just going to see how his activity is. He should not get fits. We'll see his heart rate. We will see the way his heart is beating, the way he's respiring, the way he's sucking milk, how active he is. Right now, this is all that we are going to monitor. At the same time, Mrs. Jenil, even when he gets well and he is discharged, we are going to follow up him in the clinic to see about his sitting, standing, walking, and all that is going to be monitored over a period of time. That's going to be a
Six
long journey.
minutes, 3 minutes.
Okay, doctor. Like you said, like in future also, John might have some developmental problems. Then, right? It have high chance of having these problems.
Well, because he's not cried at birth and he's required help, okay, so there are chances, there is some chance of him having this kind of problems. And with therapy, we plan to reduce it, the schooling therapy.
Still, doctor, I'm not happy because I delivered here for, tertiary hospital, and then this sort of things happening, and my baby suffered. I'm not happy, doctor. Like, it should not have happened like that, right?
Well, can you certainly tell me, Mrs. General, what are you exactly not happy about so that I can help you out?
Yeah, they should have delivered early, or they should have tried for C-sections. But they waited for so long, and then I asked for the C-sections previously also, and they were waiting for long till my baby had a nasty time.
I do appreciate your worries and your concern. Well, it probably there must be no necessity of a C-section, but to exactly explain this to you, I can have a meeting of the obstetric team with you and us together to discuss this matter further.
Yeah, that is better, doctor.
What about the cooling therapy, Mrs. Jenil? Are you happy and do you agree that we go ahead with this for John?
Yeah, if it is doing good for the baby, I'm ready to go.
Thank you, Mrs. Jenil, for your cooperation and your consent. So I would even give you leaflets and information about trusted websites about this cooling therapy so that you can know more about it. And if you have any more concerns, you can come back to us. I will even summarize what we've discussed, that John did not cry at birth and required some support. So hence, to help his brain heal further, we are going to help him with the cooling therapy. I've explained to you about the complications, and at the same time that we will have a meeting with the obstetric team regarding your concerns about the delivery time. Okay.
Okay, doctor.
At the
That
same time, I can even channelize you to certain patients who have undergone the same cooling therapy, some support groups, so that you can understand much better how their babies recovered and how such babies recovered.
okay, doctor. Thank you.
So we would really like your support, and your presence in the NICU is going to be great help for John's recovery also, where we will explain to you in minute details how things are going on, and so that you can appreciate that better.
Okay, sure, doctor.
Mrs.
Thank you.
Yes, Mrs. General. So I'll hand over the leaflets and all the trusted websites, and we'll keep on updating you about John's condition every time and about his recovery.
Okay, thank you.
Dr. Noor, time is still not up.
6 seconds left. Five
Okay.
seconds. Okay. Okay, now finish. Give comments first, Dr. Satish.
I think she convinced me well, and she was very polite, and everything was okay, but uh, yeah, but I feel she did well, but should she congratulate me because she said like, thank you for coming in, but I have just delivered the so the mother has to be, she might be in the labor room itself, right? So taking that scenario, that congratulating the baby and then starting, are you in pain, that will have been nice, even nice, before saying all these things. So otherwise it was very, very well done.
Okay. Yeah, she did not congratulate, but I think it's okay, but good to congratulate. Any comments for this? Others have any comments for Dr. Muzna? More than so many questions in the scenario, I think in the exam, the scenario will go with maybe crying and you need to offer some tissue and like this emotional thing will be more here. But still, since now role players, there can be some questions as well. So Dr. Muzna, if they ask you like, what about the feeding of my baby, what you will tell?
Oh, well, we are going to start with small amount of feeding after some time, because some feed, very little feed is essential for the gut to work nicely. But at the same time, we'll increase it very slowly, because the gut also takes time to heal and to accept the feeds.
So during the cooling therapy, you are giving feeding to the
No,
child,
no, okay, while the cooling therapy,
IV
you're
fluid.
asking me. Okay, while the cooling therapy, I thought you were asking on general for the HI. While the cooling therapy, no, well, we do not have cooling therapy at our center, but as far as I feel, there's no feeling at cooling. Well, I'm not sure. I'm not sure.
Baby should be NPO, cooling therapy during of cooling.
So the baby will be on fluids.
Yeah, yeah.
Yeah, and if the mother would have told you, one more question, if the mother would have told you that, no, doctor, I don't want it now, I will maybe after tomorrow, if my husband will come and I will discuss and tell you, what you will tell her?
Well, the effect of this therapy is good as early as it is started, especially if it started within 6 hours. You know, the brains will get a lot of time to heal. The damage is not done. So it's better we start it early.
Okay, so you will encourage her to take the decision as soon as possible. Okay, you will tell her that to contact her husband as soon as possible and let us know, because if we delay, the effects will increase. I mean, the damage to the brain will increase. So you will encourage her not to wait till tomorrow, to call him or contact him as soon as possible to give the consent. Okay, I think otherwise the scenario was fine.
This
Anyone want?
scenario generally comes with a medical student, you know, Dr. Noor, and there it is where there is criterias and everything, where this cooling therapy, I was just discussing with one of my coaches, you know, it had come somewhere in the overseas, and unfortunately that time not much was known that it can come. It was the first time it had come, and unfortunately many students back to back had flunked, it seems, because this not much is known as per a, because if it comes to a medical student, he'll ask you all the criterias, all the contraindications, what are the how to monitor everything in details. So, and you know, what is the Meditherm 3 and all that thing. So once it should be done with the medical student, the scenario, so that we come to know more about.
Okay, so before doing that, we can do it now, no problem. But before that, we will just go through a leaflet from NICE so that we will have some information to tell. Because without knowing, if we do, maybe we will make mistakes. Or if anyone knows well about it, wants to do, can go ahead, no problem. What do you say? We will go through the leaflet before, or we will do it direct?
Someone is ready, I can be the role player.
Okay, we will just quickly go through the leaflet. It is not very big, it's small. So what has NICE said? This procedure can be offered routinely as a treatment option for carefully selected newborn babies with brain injury caused by oxygen shortage during birth, provided that doctors are sure that parents and or carers understand what is involved and agree to the treatment. So this he is speaking like speaking for the parents. So we cannot use these words hypoxia, ischemia to the parents. So brain injury caused by oxygen shortage during birth. This is the word I feel it is better, because when we are speaking to parents, we have to be careful about the words hypoxia, ischemia, and all these things. So brain injury caused by oxygen shortage during birth, provided that doctors are sure that parents and carers understand what is involved and agree to treatment. Results of the procedure are monitored. It should only be carried out in units that are experienced in care of very ill newborn babies and healthcare professionals with special training in cooling treatments. So Dr. Muzna, you said you will monitor temperature, heart rate, blood pressure, blood sugar. What else you want to monitor in this child?
The bleeding profile needs to be monitored. Complete blood count needs to be seen, and blood sugars I told. And yeah.
What is the main side effect apart from the heart rate?
Bradycardia, hypothermia, hypotension, then bleeding tendencies that can take place. Platelets can go low, thrombocytopenia that can happen. Infections, predisposed to infections because hypothermia is there. And
seizure also you have to
seizures.
Yeah, they can
seizures,
also have seizures, right?
I'm not sure, because seizures, then that will be HI
Seizure
stage 2.
is already a diagnosis for HI grade 2, right? So I
HI,
think
that
seizure
is stage 2. No, that's what. And I don't know whether cooling therapy. Just one sec. I just check my notes whether that has seizures.
Okay.
Yeah, seizures can be possible when you rewarming the baby. So that's the one of the reason when you're talking to the parents, you need to be very careful. Seizures can come across when you're rewarming, especially when at the end of the cooling.
Yeah. So
coagulopathy is the one of the other side effects, which is very, very like DIC pictures where you get a
The seizures per se are not there, but coagulopathy, bleeding, and the decreased platelets, decreased immunity, all that is there. I have abnormal rhythm, prolonged QTC interval, skin injuries, increased FiO2 requirement may be there because the hypothermia can cause reduced surfactant production. Yeah.
okay.
Liver functions can also be decreased.
This is done only for term babies, not for not in preterm.
Above 36 weeks. Yeah, that's also a criteria whom it can be done. That's criteria A and B in pedia guidelines. It's in neonatal guidelines is there.
Okay. So there are uncertainties and difficulties in deciding which newborn babies might benefit from this procedure. In particular, there is little evidence about whether to use it for babies with less severe brain injury, and there are difficulties in deciding whether some babies are too ill to benefit from it. So the medical name for this procedure is therapeutic hypothermia with intracorporeal temperature monitoring for hypoxic perinatal brain injury. Okay, the procedure is not described in detail here. Please talk to your baby specialist for full description. A shortage of oxygen around time of during birth can cause brain injury in a newborn baby that can lead to death or permanent disability. There are no specific treatments for newborn babies with this type of brain injury, but standard care involves looking after these babies according to individual needs in neonatal ICU. The procedure NICE has looked involves lowering the baby's temperature from normal body temperature, that is 37 degree, to 33, between 33 and 35 degrees C soon after birth for few days afterwards, usually 3 days. So this is explanation he's giving to the mother, like normal body temperature is 37, you will reduce to 30, between 33 and 35 for few days afterwards, usually 3 days. The idea is to cool the brain in the hope of slowing down the process that cause brain damage. So we are cooling the brain with the hope to slow down the process of brain damage. It is usually carried out on babies delivered at 36 weeks or later. This we should know the criteria. It's not carried on preterm babies, 36 weeks and above. In this procedure, the baby's body is usually cooled using special mattress filled with cooled fluids. Sometimes just the head is cooled using custom-made cap. The temperature inside the baby's body is checked through the procedure, usually using probe placed in the baby's bottom. That is, usually rectal temperature is measured, placing the probe, okay? But here he's telling sometimes just the head is cooled using custom-made cap, but I'm not sure what in anyone's center they are doing the cooling. They can tell us. Here he is telling the whole body is cooled using the cooling.
Well, there is, I saw on YouTube the video, there are head caps that are available, but more than that, there is this video which shows that there's an entire blanket which is there, which is attached to the machine, and it kind of monitors the temperature of that blanket. I'll just forward the video to you, Dr. Noor.
Okay. The temperature inside the baby's body is checked throughout the procedure, usually using the probe placed in the baby's bottom, that is rectum. After the cooling period, baby is warmed up gradually until their temperature is returned to normal. This is the procedure. So in nutshell, normal temperature is 37. Using the cooling mattress, or just if you want to cool the head, custom made cap, the temperature will be maintained between 33 and 35. The reason is to prevent the further brain damage, to slow down the process of brain damage. Okay, continuously a temperature check will be done through a probe in the baby's bottom, he has written, but for us it's rectum. You can use it with the medical student. After cooling period, the baby is warmed gradually. Summary of possible benefits and risks. Some of the benefits and risks seen in the studies considered by NAIF are briefly described below. One study looked at all the results of 10 separate studies with total, across 10, I'll just read the
Actually, there are two types of cooling, therapeutic cooling, passive and active.
okay.
Passive cooling actually is that is when you don't have the machine to provide the cooling, therapeutic cooling. Then what you fill these blouses and all, or some with cool fluid, and then give it. But nowadays people are not doing scared because you cannot keep the probe temperature very nicely. But the other thing is the therapeutic cooling with the machine. Always, usually in some centers, in association with that CFM monitor, that is cerebral flow monitor, then that will give you any subclinical seizures are there or not. Because you have to start cooling before 6 o'clock, before 6 hours means that the brain damage will become irreversible if you prolong it. So if any, so you have, when you have to decide the criteria 1 and 2 are there. If the criteria, that is criteria 1 means that if the baby, if the blood gas, if the blood gas within 1 hour of life is more than, base excess is more than 16.6, or the pH less than 7.1, or the baby was given resuscitation, that is ventilation, more than 10 minutes at a stretch. And these babies, this is the criteria 1. And this is given for babies more than 36 weeks gestation and 2 kg weight or 1.8 kg weight. Then you have to, this is criteria 1 I told. Then if this baby has seizures also, you noted within 6 hours, then criteria B also mainly fulfilled. And it is corresponding to the seizures also means it is hypoxic ischemic encephalopathy, the type 2. Then moderate HIE you can give. So that is why the CFM monitor is, if you have, can be attached. Subclinical seizures can be not touched. And this CFM monitor, most of the centers, they keep throughout the 3 days, because if any continuity of the seizures are there, that will help you to assess the prognosis also. That is the thing.
Okay. Dr. Muzna, did you go through the neonatal guidelines for this? Or anyone else has gone to the neonatal
This in the
guidelines?
HI is there. See this, and Dr. Fatima and I were discussing. So very good method she taught me, of remembering this. Remember 5, 6, 7, 16. 5. Abgar of less than 5. 6. Start within less than 6 hours. 7. pH of less than 7 on CBG and ABG. 16. Base excess of more than 16. These are the criteria. Rest all are clinical, which we will remember, but these numbers we will not remember. We'll remember seizures, we'll remember encephalopathy, we'll remember abnormal tone, abnormal primitive reflexes. All this is given in HIE of neonatal guideline. But these things 5, 6, 7, 16.
And
Just
also
remember.
Number in neonatal guidelines.
All this is their neonatal guidelines.
What we went through now is for the mother to explain. It was not for the
Mother, that's why I did not tell all this, all this is not there in neonatal guidelines. See the important points which are there in neonatal guidelines not given. If the this asks you, the medical student, what is the temperature, target temperature we should keep? So that is 33 to 34 degrees Celsius. Okay.
Actually,
And how long will it continue? So it will continue for 72 hours. Then when you do rewarming, how rapidly should the temperature increase? So 0.5 degrees Celsius every 2 hours till the baby is 36.5. Okay. And 1 second. And as rightly said, that the gestation should be more than 36 weeks. This was not covered. And I told you the side effects. Meditherm 3 is the thing which is used, and the entire, which I have even shared to you on WhatsApp, the video of that Meditherm 3. Okay. And how to
the contract, actually type 2, type 3 HIE, that is when if the baby is even unconscious, that baby should not be cooled.
Not, and if there are severe malformations, if the child has other, associated malformations or almost near death, the morbidity is very bad. These are all contraindications for not starting.
Okay. So can you repeat those numbers again, please?
pH less than 7, or the base excess more than 16 or above. Within 1 hour of life. Within 1 hour. It's not necessarily be the code BGA.
No, it's good, but no, she's told 5, 6, 7. It was easy to remember.
That is the Abgar.
Abgar less than 5, less than 6 hours of birth to start.
Less than 5
less than 7 within 60 minutes, and 16 base excess of more than 16. 5, 6, 7, 16.
And 10 minutes of ventilation at a stretch, continuous ventilation.
Yeah, 5, 6, 10, 5, 6, 7, 10, 16. Then
Okay.
What Dr. Musna said, it is the criteria A. And the criteria B includes that seizures or moderate to severe encephalopathy.
So this, we should know all these things to explain to the student, you mean?
Yeah,
The
yeah. The
criteria.
criteria is very important. Suppose you, yeah, it is very important. And after therapeutic cooling and rewarming, on the day 4 or day 5, we usually, if there is a facility, do the MRI with the spectrometry. That means to assess the prognosis. That is, with the spectrometry, you can assess the sodium acetate, choline, and phosphocreatinine. So if the phosphocreatinine is low or choline is high, sodium acetate is low, the prognosis may not be good.
For the student also, we will not go much deep, but at least we should know basic things like this, the criteria to explain to her when do we go for the cooling and how do we come back. So we will just go through the symptoms we all know. Okay. 1 minute, 179. This is, it's okay. So we can just go through the immediate treatment and the treatment criteria and then the referral, and then we will do the this with the student. Okay. So the immediate treatment, prompt and effective resuscitation of the baby, maintaining body temperature, avoid hyperthermia, IV access, isotonic glucose containing IV fluids at 40 ml per kg per day. So actually all these babies go into the hypoxic ischemic injury, they may need the resuscitation because of all these things. They wouldn't have cry and the Apgar score will be less than 5. So prompt and effective resuscitation should maintain body temperature, but always avoid hyperthermia. IV access and glucose containing fluid should be given at the rate of 40 ml per kg per day. So cerebral function monitoring, start cerebral function monitoring if available. Okay, so we can just tell we will monitor only, no need to go into details. Details anyone wants can read later. When to consider treatment with total body cooling, that is the treatment criteria. Baby is more than 36 weeks gestation, meeting criteria A and B, and age less than 6 hours are eligible for treatment. So if the time has elapsed more than 6 hours, you cannot, and also 36 weeks. So infants 35 to 35 plus 6 weeks gestation but meeting criteria A and B and age less than 6 hours, discuss with cooling center as may be suitable for treatment. So 36 weeks and above you are sure, but for this 35 and above you will just discuss with the cooling center. If in doubt about the suitability of any baby for cooling, discuss with treatment of cooling. Apgar score less than 5 at 10 minutes after birth. So even in your description, they would have given this. The Apgar score was, in my case, I gave 5, but maybe they can give less than 5 at 10 minutes after birth. Continue need for resuscitation, including endotracheal and mask ventilation at 10 minutes after birth. So in the resuscitation, you may put the endotracheal tube or mask ventilation, continuously giving for 10 minutes after birth. Acidosis within 60 minutes after birth, defined as umbilical cord, arterial or capillary pH less than 7, base deficit more than 16. So this is what she was telling, 5, 6, 7, and 16, right? Less than 5 Apgar score, less than 6 hours, you should start the treatment. And the pH should be less than 7 and base deficit should be more than 16. Okay, so criteria B, seizure or moderate to severe encephalopathy consisting of, see, you are seeing some encephalopathy features like altered state of consciousness, abnormal tone, that is focal or general hypotonia or flaccid, abnormal primitive reflexes, weak or absent suck or morose reflex. So what are the criteria for moderate to severe encephalopathy? Altered state of consciousness, how you know in the baby, reduced or absent response to stimulation, abnormal tone, so hypotonia, it may be focal or general, primitive reflexes, that is morose response, abnormal primitive reflexes, maybe morose response or absent sucking and weak. So referral, discuss the option of cooling treatment with parents as soon as particularly practically possible. It is not necessary to wait for formal consent before starting passive cooling. So we have to discuss with the parents as soon as possible. So with they can start passive cooling without parents' consent. What he is telling, it is not necessary to wait for formal consent before starting passive cooling. Document discussion in baby's notes. Anyone can comment for this?
For this passive cooling, you have to start as early as possible after birth, and you keep the baby in incubator and open all the windows, or what we can say, ventilation of that incubator, and inform the cooling center to shift the baby. So that is passive cooling.
Okay, so even if they don't give the consent, we can start this procedure.
Passive cooling is at the labor room or the delivery OT, operation theater, where you resuscitate the baby.
Okay, still we haven't discussed with the parents.
Basic cooling, just don't put the baby in warmer, or means don't start the warmer, so that the temperature will be rising.
Okay, falling, you mean. As soon as decision is made to refer for cooling, referring unit to telephone cooling center and to begin passive cooling. Document this time as age when passive cooling commenced. So you will document the time with the age in hours or minutes of the baby. Documented baby's temperature at this time. Begin passive cooling by switching off overhead heater and active heating in a transport incubator. So you will just switch off the overhead heater, or the, if in the incubator, the active heating. Nurse baby in open baby therm cot with heater switched off. If baby nursed in an incubator, open path holes. Nurse baby naked apart from a nappy. Continuous rectal temperature monitoring. Insert a rectal thermometer to 6 centimeters and commence continuous rectal temperature monitoring. If the rectal temperature monitoring unavailable, perform auxiliary temperature monitoring every 15 minutes. Target rectal temperature 33 to 34. Once baby is accepted by cooling center, contact neonatal transport team to arrange transport of the baby. Discuss methods of cooling with cooling center before arrival of neonatal transport team. Use fans or gloves filled with cold water only if continuous rectal temperature monitoring is in place. Never use ice-filled gloves to cool the baby, as this can bring temperature down to dangerously low and uncontrolled levels. Okay, this much is enough. No need to go further. Even for the student, we will explain only so much. I think we should know only the criteria and this criteria A and the criteria B to explain, and also what are the symptoms and signs the baby will present. And you will start with resuscitation, maintaining body temperature, IV access, and you will start with passive hyperthermia. For active, you will be shifting with to the cooling center by calling the neonatal transport team. Okay, for what you use, I think we will tell that the cooling blankets and the cap, special cap will be used, right? So anyone wants to be the student now? Who wants to take the scenario?
I can do if you want.
Okay, Dr. Muzna, you want to be the student?
No issues.
No, I mean the role player, sorry.
I know, I understood. The student, no, that means.
Yeah, you are the student and yeah, okay, yeah. Okay, if you people want to start, I will set the time.
Yeah, you can set the time.
Okay, start 6 minutes I have set. Yeah, as soon as you start, I will click here.
Yeah. Hello, good evening.
Hello.
Yeah, this is Dr. Pankaj, one of the registrar. I believe I'm talking to Muzna.
Yes, Dr. Pankaj. Yes.
Yeah, nice to meet you today.
Thanks. Same here, doctor.
And how is going your rota?
Yes, doctor, it's fine, and I'm enjoying pediatrics. In fact, I have a keen interest in neonatology.
That's great, fantastic. Because to deal with the small babies is always good. We always feel good while dealing with them, right?
Right, doctor.
That's great. So, Muzna, I believe that you wanted to talk to me regarding that baby, which we are doing, right?
Yes, doctor. I saw this baby yesterday, and I was just shocked. I don't know probably about this, that this child is being cooled, and how is it going to help? What effect does it have? I absolutely have no idea about that.
Okay, that I will explain you. But have you ever seen other babies, or have you ever heard, or have you ever studied in the books regarding this cooling, therapeutic cooling?
No, doctor. I just read that it is used in something called as hypoxic ischemic encephalopathy. I was reading yesterday before coming to meet you. So there it is used, but how it is used, when
Yes,
exactly we should use it? I couldn't understand all that.
yes, that's excellent. Fantastic that you know HIE also. So I'm happy to know that. So let me explain you. Actually, usually we do this therapeutic calling in babies who are born after 36 weeks of age, gestational age. Mhm. Are you there?
Okay.
And actually we need to, after delivery, we need to discuss with the relatives. We need to take their permission, consent, and then we inform the cooling center. Hmm?
Okay.
So they
Okay.
will they will get everything ready for the baby. Hmm. Okay,
Uh-huh.
so can you imagine with me that when baby is born and HI baby, so what may be the situation at birth in such babies?
That's what I was thinking, doctor. Let any baby who doesn't cry, like yesterday also I
Mm-hmm.
attended my delivery. So he did
Mm-hmm.
not cry, but I think after stimulation he cried in 1 minute. So why was
Mm-hmm.
cooling therapy not carried out for that child?
Yes, that's a very good question. Fantastic. So what happens when you usually baby cries within 3 minutes, right? Then there is no
Mhm.
damage, no much damage to the brain. But those babies who cry or oxygen is reached to the brain after 5 minutes of birth, then there is a lot of chance that we can have the brain damage in long term. Mm-hmm. Are you with me?
Okay. Okay.
Yeah. So in our practice or in our research, it is found that if we do therapeutic cooling, means induced cooling of the brain, then the damage like apoptosis, you must have read about the apoptosis, right?
Yes, yes, apoptosis and necrosis in pathology, I
Yes, yes.
remember.
So brain cells death or irreversible damage to the brain, they starts after a couple of hours of the life. Mm. Or we maybe you say 1 or 2 days. So if we do this type of cooling of the brain cells, their metabolism is slowed down. So metabolism is slowed down, so damage is also going to get slow. Am I clear so far?
Okay, okay, doctor. So,
Mhm.
which conditions can we actually go in for this?
Yes, yes. So this is very nice thinking. Uh, so we have plan A and plan B. So in plan A, if the baby doesn't cry in Apgar score is less than 5 or less than 5, if we have to prolong intubation till 10 minutes. And plan B, if the baby is having fits or moderate to severe HIE, so we have to plan accordingly. Am I clear so far?
Okay,
Mhm.
okay, okay, doctor. Okay. So, but I was seeing the sister continuously writing some notes in the file. What are we doing? How do we monitor these children basically? He was
That's
continuously monitoring.
That's nice. Actually, this is a very grand, what we say, very skilled process in which keep the baby with the. We have two options. One is the cooling cap, and another is the blanket. It depends on the center. Hmm? After that, we have to monitor a baby's rectal temperature continuously, and then we monitor the coagulation profile. We monitor the heart rate, pulse rate, blood pressure, sugar, electrolytes, and sometimes ABG. So all these and skin also, because of that cooling blankets, skin may get damaged. So all these we have to monitor continuously, and sometimes
Okay,
baby can have fits also, but that is very rare with the perfect hands or when we have a skilled team. Are you there, Muzna?
yes, 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 doctor. Yes,
Yes.
I am
Yes.
understanding. And
Mhm.
doctor, this
Yes.
nurse was also continuously like she was telling I have to after certain some 12 hours or 6 hours I have to do blood test. So what
Mhm.
do we keep on doing? Like what was she? What test does she
Yes.
keep on?
Yes. That's a very good question. Actually, we need to monitor the as I said, electrolytes and blood sugar, and bleeding like platelet count, CBC. Mm. So all these routine tests or parameters we have to keep a close watch. There may be sometimes bleeding or sometimes coagulation or DIC can happen. So
Okay, okay,
these are the complications of that procedure.
okay,
Mhm.
okay, 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 doctor. Okay. And do we
Mm.
require like to do any sonography for this child, for the brain or anything, doctor? Like, how do we come to know that will be a delayed child or something?
Yes, Mujna, can you think with me? Sonography. Do you know any idea that at what day we usually do jelly scan or USG of the brain, newborn babies usually?
We do not usually do for sonography for newborn babies, as far as I know.
No, when there is any intracranial bleeding or any other birth
Okay.
asphyxia, so
It is for
that we.
preterms, doctor, but
Mhm.
I don't know
Yes.
exactly which day. I think third day.
Yes, very good. Good knowledge you have. So usually on third day we do here in other babies, but in cooling, we can keep a close watch on third or fourth day when we are doing passive cooling, active cooling, so that we can do. Hmm? But if we are
Okay.
using the cooling caps, then we have to defer for 1 or 2 days. So maybe on day 4 or 5 with the consultation of the neonatologist.
Okay.
Uh,
Okay. Okay.
yes. Any other question you have, Mujna?
No, no, that's a thank you, doctor. I'll even have my own reading for this.
Okay, that's good. So what I will do, I will give you some written notes and some trusted good websites like nice guidelines, so you can go through them. Good textbooks also there, so you have a detailed knowledge regarding this, and
Yes.
you can prepare a seminar if you wish for your friends also.
Yes, yes, doctor. That's a good idea.
I will help you on that. So Mujna, can you summarize what we have discussed today?
Yes, doctor, you told me about the cooling therapy and what are its indications, how do we monitor, and
Mm-hmm.
what investigations do we do, what are the side effects of that, and yeah, that's all that we discussed about.
Yes, that's fantastic. You are grasping everything very fast. You are a bright student.
Thank you, doctor.
You are welcome, and I wish you all the best for a bright future. If you have
Yes,
any other questions or queries regarding this baby or other babies, you are always welcome. Hmm?
yes, yes. Thank you.
Thank you, Mujna. Hmm?
Welcome.
Nice to meet you
Uh,
again. Time not sorted or not? No warning on 6 minutes.
Yes,
I
even
told,
six. I was
I told also this also what my alarm also made sound.
Okay.
I
But
also
you
missed it,
also,
doctor.
you also missed it. I told. So this is the second alarm time. It was on time.
Okay, without.
I think the scenario went well, not bad.
Okay, ultrasound when it is done on day 4 5, just like
I
MRI
think
or what?
MRI is done between day 5 to 14. That's
So
what I
when we
have
do a
written.
USG, because if he is
Between
wearing the cooling cap, then very difficult to remove and do ultrasound.
no,
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 usually,
MRI,
no,
MRI.
no. That
Ultrasound
time,
is not done. MRI is done between day 5 to 14 of life. That's what I have written here. I think it's
yeah,
from neonatal guidelines.
ultrasound is not done when the baby is getting cooling. It is done usually on day 5. MRI will be done.
Okay, if it is the exam scenario, then I will say that I will get back to you. Okay.
Okay, for both head cooling or cooling with blanket, all ultimately on 5th day. For 3 days we will do cooling, and the MRI will be done on the 5th day.
Yeah, 5 or 6 days.
Between day 5 to day 14. I have
Yeah,
written, I think, I don't know from where have I think from neonatal guidelines, I've written this in my notes.
yeah, it can be done, but usually do on 5th or 6th day, but it can be done on day 14 also. And also when we criteria, when we say the agar of 5, the agar 5 at 10 minutes of life. That we have to mention.
Less than
Yes,
5. Less
yes,
than
yes.
5 or 10 minutes of life.
Yeah,
5 or less than 5 at 10 minutes of resuscitation into
yeah.
equipment.
And he was telling that if they more than 5 minutes, if the baby did not cry, is this the criteria there?
No, no, that is
Or
not the
not there,
criteria.
right?
Actually, cry is not a criteria.
No,
in
no,
a
criteria. I said this is that we do brain damage when there is more than 5 minutes, then brain damage can happen. I was talking about HIE, not about the criteria.
Because cry is not actually the assessment.
Mm.
The breathing effort is the assessment more than cry. Cry is not the assessment at all.
Yes.
When the baby started breathing, that's it.
No, I said oxygen for the brain is important. Oxygen should receive to the brain within 3 minutes or max 5 minutes.
Yeah.
So HIE damage or definition.
So he told that if the baby cries within 5 minutes, the damage to brain is less. Prolonged more than 5 minutes did not cry, there is more chance of damage to brain. This is what you were conveying the message, right?
Correct.
Okay. Last time we did the scenario of retinopathy of prematurity and it did not go well. So I want to repeat it. I will do it. Anyone wants to be the role player?
If you have fixed question, then you send me on WhatsApp, then I can become.
No, I don't have any fixed
I
question.
can try being the role player. Just one second.
Okay. Because for me, I don't have much experience with neonates, but at least basic things I know.